Hi. So let's come to another episode of clinical case discussion. This is Dr. Bharat Kumar. So today we are going to see a clinical case discussion of a parotid swelling. So before we go into the actual case sheet details and all, we need to look at the basic anatomy points that are relevant to parotid swelling. Okay. So you know that parotid gland is one of the most important major salivary glands. Sometimes, rarely, there can be a an accessory parotid gland. This is called Socia parotidis. Okay, so there is nothing but accessory parotid gland, most commonly seen at around the parotid duct. Okay, so and the two other major salivary glands are one is submandibular gland, next one is sublingual gland. Right. We know that parotid gland has got two lobes. So one is superficial, second one is deep. So where is this deep lobe of parotid gland present means it is located in a very specific and unnamed site called Stylomandibular Tunnel of Pate. Okay, Pate is the scientist name. So you can see here Stylomandibular Tunnel. It is nothing but the space between styloid process, as the name itself says, styloid process, and the other one is mandibular ramus. Whatever the location that is present in between these two bony landmarks is called stylomandibular tunnel of Pate, where the deep lobe is present here. As you can see in the picture here, this is all the deep lobe of the parotid gland. This is important because whenever there is involvement of both superficial and deep lobes swelling, it gives something like a picture of a dumbbell like this. Okay, so this is regarding stylomandibular tunnel of Pate. Next, this is an important anatomical landmark when we are doing the surgery, especially when we are doing superficial peritectomy. How do we know that this is superficial, this is deep? There is an important anatomical landmark called fascia venous plane of Pate. So, as the name itself says, fascio means facial nerve here. Then venous. You can see here the important vein which is present is retromandibular vein. So superficial to deep. This is the superficial one and this is the deep one. So superficial to deep, what are the structures present in this facial venous plane of Pate means most superficially you have facial nerve, then retromandibular vein, then external carotid artery. More or less it will be terminating into two important branches. So this is the external carotid artery. It will be dividing into two important branches. One is maxillary artery, another one is superficial temporal artery. These are the two important terminal branches of external carotid artery. So these are the structures present in this fascia venous plane of Pate. Next, parotid duct. So it is a major salivary gland, right? It has to secrete the saliva and all. What is the anatomical configuration of parotid duct? So this parotid duct is also called Stenson duct. So this is the Stenson duct. What is the course of Stenson duct? This is the anterior border of the parotid gland. So this is the parotid salivary gland, parotid gland. At the anterior border of the gland, it takes its origin and it passes superficial to the masseter muscle. So this muscle is nothing but masseter muscle. Then at the anterior border of masseter muscle, it takes 90 degrees turn like this and it pierces three important structures. So you can remember three B's. What are the three B's? This is the buccal pad of fat. This one. Buccal pad of fat. Second one is this is the buccopharyngeal fascia. So buccopharyngeal fascia. Next is this is the buccinator muscle. Buccinator muscle. These are the three important structures which will be pierced by the Stenson's duct. And after piercing the buccinator muscle, it will take again another 90 degrees turn. And eventually, this will be opening opposite to the, where is it opening? Opposite to the crown of upper third molar tooth. Upper third molar tooth. Okay, so the opening of the parotid duct is present at opposite to the crown of upper third molar tooth. Okay, right. Similarly, we are having, just like we are having a parotid duct, we are having submandibular duct opening, which is called Barton's duct. Okay, so this is another important point we need to understand. What is the name of the submandibular duct? It is Barton's duct. What is the course of submandibular duct? Again, it is important to remember the course of Wharton duct as well. Just like we are having superficial lobe and deep lobe to parotid gland, for the submandibular gland also we have superficial part of the submandibular gland and deep part of the submandibular gland. The course of Wharton's duct is at the anterior end of the deep part of the gland. This takes its origin Wharton's duct. Then it will travel in an anti-gravity fashion where on the hyoglossus muscle. This is the hyoglossus muscle we are having, and on the hyoglossus muscle, it travels on the hyoglossus muscle between the hypoglossal and the lingual nerve. Two important nerves we need to remember regarding course of submandibular duct is one is lingual nerve, second one is hypoglossal. Sorry, hypoglossal nerve. Okay, so after traveling between these two structures on the hyoglossus muscle, at the anterior border of hyoglossus muscle, it is crossed by lingual nerve like this. Then it will opening to the floor of the oral cavity on either side of the frenulum linguae. Okay, so this is the submandibular duct we are having. It starts at the anterior border of deep part of the gland on the hyoglossus muscle. In between hypoglossal nerve and lingual nerve, it will travel, and eventually, as you can see, it is a anti-gravity fashion. It is traveling in an anti-gravity fashion. I'll tell you why it is important. And eventually it is opening onto the floor of oral cavity. Floor of oral cavity on either side of the frenulum linguae. Okay. Why is it important to understand that the course of Wharton's duct is in anti-gravity fashion? You know, out of all the three major salivary glands, which salivary gland has got more risk factor for developing calculi means it is submandibular gland. Why it is so? Because there are three important reasons. So why is submandibular gland has more chance of getting calculi means one, the secretions of the submandibular gland itself is very viscid. So more viscous secretion. This is for submandibular. Please understand. Submandibular. Why is submandibular gland having more chance of developing calculi? One is more viscous secretions. Second one is, as you can see here, the course of the submandibular duct is anti-gravity drainage. Anti-gravity drainage. Third one is, in the course of the submandibular duct, it is crossed by lingual nerve here. You can see here, this is the lingual nerve crossing this is the lingual nerve crossing the submandibular duct. So, duct is crossed by lingual nerve. Why is it important? Because sometimes at this juncture there can be a little bit obstruction and all the secretions will be pulled up. Again, there is more chance of calculus formation. These are the three important reasons why submandibular gland has highest risk of calculi or most common highest risk of calculi. Okay, so this is the question, this is the answer. Right? Next, what is the name of the sublingual duct? As you can see here, the name of the sublingual duct is Rivinus duct. And where is it opening? It can either open into the Wharton's duct or into the floor of cavity, directly into the floor of the oral cavity. Okay, right. Next. Then coming to the nerve supply of parotid gland. So regarding nerve supply, it is very important to understand. One is sympathetic drainage, second one is parasympathetic drainage. One is sympathetic, second one is parasympathetic. Parasympathetic is also related to your secretomotor pathway. Okay. So what is the sympathetic supply? As you can see here from the T1 spinal segment, this superior cervical ganglion is the main source of sympathetic drainage. After forming a plexus at around internal carotid artery, this will supply the sympathetic supply to the parotid gland. Coming to parasympathetic, it is very important to understand the main source, the signal comes from inferior salivatory nucleus, whereas the submandibular gland will get the signal from superior salivatory nucleus. Okay, so first point is inferior salivatory nucleus. From there, the nerve is ninth cranial nerve, which is nothing but glossopharyngeal nerve. Then a branch of it, it is nothing but your tympanic branch. After forming the tympanic plexus, the signals travel through lesser petrosal nerve here. Okay, so this is the lesser petrosal nerve. Then, along with the mandibular nerve, it will relay in otic ganglion. So this is nothing but otic ganglion. So, what is the preganglionic parasympathetic fibers? So again, you can remember here. So preganglionic and postganglionic. So preganglionic is by glossopharyngeal nerve, followed by tympanic branch of the glossopharyngeal nerve, then lesser petrosal nerve. So this is the order in which it is carrying. Next, after the relaying, the postganglionic fibers are mainly by auriculotemporal nerve. So the main source of postganglionic supply is auriculotemporal nerve. Okay, so this is the important nerve supply. Why do we need to understand nerve supply? Means there is an important pathological condition after superficial peritectomy. Few people will get an important syndrome called Fraze syndrome. We will see the details subsequently. So this syndrome is called Fraze syndrome, which is also called gustatory meal syndrome. Okay, or gustatory sweating. It is nothing but gustatory sweating. Right. Next. So this is the same flowchart that we have seen just now. Now, coming to the lymphatic drainage, you need to understand there are two important sources of lymphatics here. One is superficial, second one is deep. The majority of the lymphatics are superficial, of which 90% are present in parotid sheath. Okay, so the surface has got the more lymphatic drainage, and remaining 15 to 20% will be present in the parenchyma of the parotid gland. Ultimately, they will be draining into either level 2 or 3 cervical lymph nodes, mainly level 3. Okay, so nothing but upper jugular and middle jugular group of lymph nodes. Right. Next, what is pes anserinus? Pes is nothing but it is a technical term for foot. So you know from anatomy we have learned it is nothing but it is just like a crow's foot. It resembles like a crow's foot. What is this crow's foot? Anserinus is nothing but it's a network. So what is the network? Pes anserinus is nothing but it's a network of or branches communication branches of, where is it present? In between the branches of facial nerve. In between facial nerve branches. So we know that as you can see here in the picture, this is the main trunk of facial nerve. Once it enters into the parotid gland, it will be giving two important divisions. So facial nerve will give two important divisions. One is temporofacial division. Second one is cervicofacial. So it gives again two important branches. It gives again three important branches. As you can see here in the picture, this is the temporofacial division, and this is the cervicofacial division. Temporofacial division again is giving two important branches. One is temporal, second one is zygomatic. Whereas cervicofacial is giving three important branches. One is buccal branch. So this is the buccal branch. Second one is mandibular branch. Last one is cervical branch. Okay, so these are the three important branches given by cervicofacial division. This is the cervicofacial division. So As you can see here in the picture, there is communication in between the branches of facial nerve. That communication is that network is called pes answeriness. Okay, right. Next, what is the importance of knowing about these nerves in the parotid gland and all? There is an important point what we need to understand. It is nothing but intraoperative identification of facial nerve. Intraoperative identification of facial nerve. So for this, we have two important methods of identification. One is antegrade method. Second one is retrograde method. We will see the details subsequently in the operative surgery part. So antegrade method and retrograde method. What is antegrade method? First, we will identify the main trunk of facial nerve. Then we will go in a antegrade version to identify the branches. Whereas in recurrent surgeries of the parotid gland, repeat surgeries, first we will identify the one of the branches of the facial nerve, then we will go in a retrograde fashion to identify the facial nerve trunk. So this is the basic anatomy details of the parotid gland. Now, what are the important differential diagnosis of a swelling which is present in the parotid region? Okay, so before we go there, what is parotid region or parotid zone? These are the important anatomical land boundaries. There are two types of boundaries that we need to understand. One is anatomical boundaries, then second one is topographical boundaries. Anatomical boundaries, as you can see here in the picture, it is nothing but a more or less a pyramidal shaped gland where anteriorly it is bound by masseter muscle. So it is nothing but masseter muscle. Then posteriorly you have got sternocleidomastoid muscle. Then superiorly this is nothing but zygomatic arch or zygoma simply. Okay. So zygomatic arch is the superior border, masseter is anterior, sternocleidomastoid is the posterior one. Then coming to the topographical landmarks. What do you mean by topographical landmarks? Just by looking at the patient here, how do you know this particular region is parotid region or which is also called parotid zone? See, this is the zygomatic arch we have. Then roughly this is your angle of mandible. Posteriorly, you have got a mastoid process. Okay, so it is nothing but mastoid process. Now, topographical landmarks we can easily remember. One, there are two important horizontal lines and two important vertical lines. Okay, so what are the horizontal lines we have here? So one superior horizontal line is passing through the zygomatic arch like this. Then inferiorly another horizontal line is drawn passing through the angle of mandible. Now, this is the midpoint of zygomatic arch. This is the zygomatic process, right? So, this is the midpoint of zygomatic arch where we are drawing one vertical line anteriorly passing through this. Then again, posteriorly, one more vertical line is drawn passing through the tip of the mastoid process like this. Okay. Whatever the area that is present here in between this is all is called parotid zone or which is also called parotid region. What is the clinical significance of knowing this? Whatever the swelling which is arising from the parotid zone is considered to be a swelling arising from the parotid gland unless proven otherwise. I repeat, any swelling which is present in the parotid zone is considered to be a parotid swelling unless proven otherwise. Okay. Now, another important anatomical point we need to understand is when we are examining the parotid gland, how do we palpate for parotid duct? So we need to understand where the topographical location of the parotid duct is present. As you can see here in the picture, at the anterior border of the gland, it is rising here, passing on the superficial to the masseter muscle. So how do we correlate it clinically? You need to understand there are two important marks. So this is the tragus. Here we will keep 1 point. Then anteriorly we will keep this is the ala of the nose, this is the angle of mouth roughly. So midpoint of ala of the nose, midpoint of ala of the nose and angle of the mouth. So we will draw a line connecting these 2 points, an imaginary line. Then the middle one third of the line will correspond this parotid duct. I'll just draw here. This is the tragus we have. So this is the midpoint between ala of the nose, and angle of mouth. We will draw this line. We will join these 2 points. So we will divide it into three parts. This middle one third corresponds to parotid duct. So that's where we will palpate for parotid duct for any stone or any malignant growth that is there. We will ask the patient to clench the teeth to make the masseter contract. Again and again the against the taut masseter muscle, we will palpate for the parotid duct. Okay, so this is called parotid zone, and this is the topographical landmark of parotid duct. Nothing but Stenson's duct. Now, what are the important differential diagnosis of a swelling which is present in the parotid region? Apart from the parotid gland, there are some other anatomical structures which can give rise to a swelling. So it can be divided into something like a solid and a cystic. In again, based on the etiology, important congenital conditions which can be there in parotid region is one is dermoid cyst, second one is hemangioma, then lymphangioma. Within the parotid gland, what are the possible swellings we can have means, again, benign conditions are something like a pleomorphic adenoma, and cystic one is your Warthin's tumor. Malignancies, it can be something like a adenoid cystic carcinoma, malignant mucoepidermoid carcinoma, etc. Apart from the parotid gland which is there is subcutaneous fat present here. From that fat, there can be a lipoma which can be arisen. Then I told you there are abundant lymphatics present and lymph nodes also present here in the preauricular region. So one, it can be TB matted lymph nodes. When the stage is advanced, it can form a cold abscess. Then there can be a malignancy arising from the lymph nodes present here. Rarely you will get, but possible. So it is nothing but non-Hodgkin's lymphoma. Another important point you need to understand is, rarely in an advanced stage, whenever there is a oral cavity ulcerative growth, this can metastasis to preauricular lymph node. So that will give metastasis to that preauricular group of lymph nodes. Very rarely you can have neurofibroma, which can be happening from the nerves present in this region. Okay, so these are the important differentials for a swelling present in the parotid region. For the parotid gland per se, what are the possible differential diagnosis of means of that particular swelling means? It can be painless or painful. So you know any inflammatory swelling is usually mainly painful. So it can be mumps parotitis. Usually it will be bilateral, or it can be acute bacterial parotitis. So mumps is a virus, and it can be bacterial parotitis. Post-operative parotitis, usually again it is bilateral. In ICU set of patients, where the oral hygiene, if it is not maintained properly, it can lead to postoperative parotitis, which is more commonly bilateral. Then recurrent parotitis of childhood and sialadenitis. These are the common painful conditions. Now, what are the painless conditions? It is one of the main benign tumors like pleomorphic adenoma and Warthin's tumor, or malignancies in an early stage like adenoid cystic carcinoma or mucoepidermoid carcinoma. When these carcinomas, when these malignancies infiltrate the nerve, there can be pain around in this region. Then next is mucoepidermoid carcinoma. After that, very miscellaneous conditions like rarely you can get. One is first branchial arch cyst, then hemangioma, then lymphangioma. So these are the possible swellings which can be arisen from the parotid gland itself. Okay. So we will look into the case sheet details in the next part of the video. Thank you.